So here's Brett O'Brien.
So I'm going to start us off. My name is Brett O'Brien, and I'm the Director of Children, Youth, and Prevention Services here for the County of Orange in California. And good morning or good afternoon to you, depending on where you are. It's still morning here. So we wanted to just share with you our experience of a particular project that we started, and I wanted to give you a little bit of background into why, what we were doing, what was our motivation, and then we'll lead into how what we're doing now. So first of all, just to make sure we're all on the same page, and since none of you are wondering what SBIRT is based on that last poll question, it seems that everyone is familiar with it, but just so that we're all on the same page. Screening, a very brief set of questions to identify risk for substance use problems. I think most traditionally alcohol is how it started out, and it has been expanding, and we've certainly expanded it beyond substance use, and we'll share about that. Brief intervention is a brief counseling that raises awareness of risks and motivates clients toward acknowledgement of a problem that they are using at risky levels. And then a referral to treatment is procedures to help patients access specialized care. So to give you some background into how we got to where we are today, wanted to share with you, first of all, that back in around 2009, 2010, I am involved with our state association, and so I often go up to Sacramento and with all of my counterparts, and we have a state association, and we receive trainings and presentations a lot. We started receiving a lot of training on SBIRT, and a lot of information was coming out about SBIRT about that time, and I had not heard much about it prior to that, and so I came back thinking that this is something that we really need to consider doing, and some of the data or much of the data was just very compelling to me, and so just to give you a little bit of the things that really impressed me was that in the U.S. we have over 300 million people, including more than 240 million adults. Well, in the National Survey on Drug Use and Health in 2012, reported that over 20 million people in the U.S. needed but did not receive treatment for substance use disorders. Well, that's something that impressed me, because that's what I have been doing for the last 28 years, and I've been the Alcohol and Drug Program Administrator here for the county over the last 8 years, and so this is very of great interest to me personally, because that's what I'm about. It's what I've been doing for my career is alcohol and drug treatment. And when you see this statistic of so many people who need help but are not receiving it, and then this next statistic of 11.5 million adults in the U.S. needed it but didn't receive treatment. Well, this is for mental health disorders, needed but did not receive treatment for mental health disorders, and then there's a whole bunch more who are in need but don't even know that they're in need. And so one of the ways that we have been learning about through this SBIRT is that SBIRT is a great tool for identifying and helping individuals not only not only to determine that there is a need, but to help them to come to some kind of a conclusion that they are using risky behavior and try to motivate them to change that behavior. So we wanted to also around 2009, 2010 is when there was much talk about the Affordable Care Act and changes in the health system upcoming, and much focus on integrating behavioral health with primary health care. And so we thought, well, this is something that we really ought to take a look at, is how do we move in a direction of integrating our services, our alcohol and drug treatment services, with primary care. And so we started to take a look at who could we partner with, who would we be able to join with that in terms of the medical field and the primary care settings within our county, that we could maybe begin some sort of a project of doing SBIRT and begin to integrate care. We began talking with hospitals, and some of the hospitals in the area here, and talking with the directors of ERs and trauma centers. And one of the questions that kept coming up was that, well, and let me just back up a little bit. We had identified some funding that we wanted to dedicate to this project, and so we had from our budget we had decided to call out about $200,000, which we figured would cover the cost of two staff to do, and what we thought we would do is start out with licensed staff, actually, so licensed clinical social worker, licensed MF marriage and family therapist, to begin this. And so we thought we had identified some dollars to do that, and so we explained this to the individuals that we met with in the primary care and the ERs and trauma centers and such, and they thought, well, why don't you just give us the money and we'll hire the people to do that. And well, we thought, well, no, that's not what we want, because we want to begin integrating our services, and so that was not what we wanted to do. And so we continued our search, and we finally came across our partner that we are with now, and that's the University of California at Irvine Family Health Center that they have here. Interestingly enough, like a 5-minute walk from my office here, and they have a full-fledged FQHC there, and it's a very, very busy clinic. And we began a partnership where we began to identify, well, what would we like to do? What do we want to accomplish in SBIRT? And in working with them, one of the things that we needed to do was not just do substance use screening, but also mental health screening. And the reason for that is the funding that we had was from what is called the Mental Health Services Act here in California, also known as Proposition 63, which is a 1% tax on individuals making $1 million or more, and those dollars specifically would go to the treatment of mental health. And this actually was voted in around 2001, I believe, and so, or not that long ago, 2010. But anyway, so it was funding that is allocated specifically for the purpose of mental health services. And so we knew that we needed to expand. In order to use these dollars, we needed to use it to help us identify individuals with mental health disorders as well. So as we worked with UCI, we began developing a tool that will be discussed later on, which not only screened for substance use or drugs, it screened for drugs, alcohol, depression, anxiety, family violence was something that was very important to the medical center that they wanted to screen for, and we also wanted to screen for trauma. And so we began to do a lot of research, and we found short screeners that we could use, such as the GAD-2 for anxiety, the PHQ-2 for depression, and so forth. And again, we'll go into these a little bit later. And if we would get it, and these are validated, and so whenever we would get a positive on any of those, then it would lead to a greater screen. And so that's what we ended up with, and we came up with a 10-question tool that we've been using now, and and you'll see the data on it as we go forward. So basically, we did this because we wanted to integrate our behavioral health services, mental health as well as substance use, into primary care. But that's not the only reason. The statistics on SBIRT were very compelling, as I mentioned, and having the potential to identify individuals who are going into a medical setting, let's say because they cut themselves, and then as you go through the SBIRT screening, you find that, well, they cut themselves because they were drunk or something, that the just a brief intervention there had such great impact through all the studies that we've seen that it would reduce the return visits to ERs just based on that screening. And so we thought, we've got to do this. This is something we must do, and so that's why we pursued it. Not to mention all the data on the cost savings that is attained by the reduction of people returning for drug-related or alcohol-related incidences. So that was what got us started, and so we began the process of hiring a couple of staff. And then what happened was this started several years ago. We didn't actually get started. The actual project didn't start until this past July. So we've been in operation now. Was it July? July. Yeah, in July. And so we've only been in operation with this for about 10 months. And the reason why it took us so long is because we needed to develop a memorandum of agreement between the two agencies, the county, which is what I work for, as well as UCI, and that was a long process. And because we had to get it vetted, we had to go through all the various councils and such, and so we hired our staff, and they weren't really able to do SBIRT for quite some time until we finally got the MOUs in place. But once we got the MOUs in place, we were off and running, and so we'd like to share that experience with you. So I'm going to turn the time over now to Cary Clevenger, who will take it from there. And so are there any questions up to this point?
Christina?
No, I don't see. None have come in yet. Thanks, Cary.
Okay. All right. So basically, because this was a sort of limited funding project and stuff, when we went to hire staff, we actually went into a local Craigslist, and we found Tani. It was very hard to find licensed staff who were also bilingual, and so we found Tani, and then she had a friend that she worked with, Elaine, and so we hired the two of them. And as Brett had mentioned, during the process of developing the MOU and stuff, they actually got licensed, which worked out, because what we didn't realize when we were working with the folks at UCI was that they had a whole administration that had some different ideas about some of the things that we were trying to accomplish. So during the 2 years or so that it took us to get this off the ground, some staff had switched over, and then they were developing an electronic medical record. And so we were trying to negotiate with them in terms of how we would do the SBIRT, like in terms of whether they would put it into their electronic health record, or we would have like iPads with the questions in them, or we would just use paper. Also, we were trying to figure out if they were going to administer the questions themselves, or that they were going to be handed out and by the clerical or by the medical assistants, and then the patients would fill them out on their own. And what we ultimately decided to do was to have Tani and Elaine do the screenings themselves. And so part of the thing with waiting for the MOU, we're negotiating some of that stuff. We had to figure out where Tani and Elaine would then see the patients, and we determined through talking with the staff at UCI that the best thing would be for them to be seen in the waiting rooms while they're waiting to see the doctor. If when you go to see the doctor, basically, you get into a room, and then you're queued for the doctor, and then it takes the doctor some time to get to you. So in the exam rooms is where Tani and Elaine would meet with the patients while they waited for the doctor. And they really worked well with the team in terms of getting, working in with their work flow. So if the doctor comes in, they'll discontinue the the questions and then come back in after the doctor finishes, or if they need to do further work with the patient, they'll come back after the doctor finishes with the patient. I got a little bit off there. You know, some of the legal issues that we also had to deal with were, you know, who would hold the confidentiality, who would hold the records, and it was determined that UCI would be the holder of the records because it was in their facility. And so once we got the MOU signed with the mutual indemnity, and that was when we found out that in order for them to work at UCI administrative staff got involved, and then both Tiny and Lane had to go through their whole hiring process. So like Tiny and Lane had gone through our process, they passed their background checks and got fingerprinted and had TB tests and all the things that we have to get them to do. And then they had to go through a credentialing process through UCI and also a background check and a physical there. So, and then at that time, well, it was right about that time that they got licensed. So for a while, they're like, oh, well, this isn't going to work because they're not licensed. And then we're, okay, well, now they're licensed, so now it's going to work. And it was on again, off again for some time. But we made good use of that time with them because basically while they were waiting for the project to get started after we'd hired them, they spent time working all of our drug and alcohol programs. So from the court programs to our perinatal program and our AOD program. And so they got very familiar with the drug and alcohol addictions treatment here in the county. And at the same time, they also developed a lot of resources. They worked on a resource guide and spent, you know, quite some time contacting, 6 months, contacting the various programs around the county to try to make sure that when they did identify mental health or substance use disorders, that they would have somewhere to refer them to. So I think that's it for that slide. Our modified SBIRT tool is obviously, as I stated, conducted face-to-face. It's a 10-item brief screening based on validated tools. So like the depression is, the screen is based on the PHQ-2, and if they score high enough on that test, they are given up a full screen follow-up test of the PHQ-9. With anxiety, it's the GAD-2, and then it goes to the GAD-7. With alcohol misuse, the questions are based on the Audit-3, and then the Audit-10 is given for follow-up screening. And for the drug abuse, prescription abuse, it's the NIDA Quick Screen, and the questions are adapted from the NIDA Quick Screen, and then they're given the DAS-28 if they score positive on those screening questions. And for trauma, that question, well, we kind of updated it in April, so the results that we're presenting today don't include all of the trauma. Not as much of the trauma was identified through the previous edition of our first attempt at the tool. We modified it a little bit more just this past April. So if the patient exceeds the cutoff score of the initial questions, they're given the follow-up questions. And I guess that's it for that one. I'm going to go from that now to some of our results in terms of the data that we've collected with regards to the patient screens. So between July 2013 when we started and February 2014, we screened a total of 4,296 patients. Of those patients, 99% were screened using the modified SBIRT, which averages about 532 patients per month. So it's quite a number of patients that Tanya and I are seeing between the two of them. 40 patients were not screened because of language barriers or special needs, and there was a very select few of patients who declined the screening altogether. So with regards to the demographics, here in Santa Ana, we have a very large Spanish-speaking population, immigrant population, and so what's seen at UCI in terms of SBIRT screenings is 67% are women, 33% are men, and 60% are age 50 or older, and 34% are age 26 to 49, and 6% are age 18 to 25. No children are screened. So it's a largely low-income Spanish-speaking population. Of the total screens that they did, 28% of them were considered positive screens. 86% were for mental health disorders, 9% were for substance use abuse disorders, and 5% for domestic violence issues. And 9% screened positive for more than one issue, and those were mostly mental health and substance use disorder. It was kind of a shock a little bit for us with the findings. We were very encouraged to know that 54% of the positive screens identified an untreated issue, which was what our target was in doing this project in the first place. And we really thought we'd be finding a lot more substance abuse than we did, but ended up finding a lot of mental health issues. So it was good that we had decided to include all the different areas to screen for rather than just substance abuse. Again, like Brett had mentioned, that came out of funding issues. Okay. So of the patients that were discovered to have an untreated issue or needed referral, basically 81% were sent to community services, and then additional 10% were sent to our adult mental health system within the county, and 8% were referred to our county alcohol and drug programs, and then 1% were referred to our crisis assessment team. So those are a few folks who actually had a urgent mental health condition that needed treatment. Follow-ups, patients who visited the clinic multiple times were screened using modified SBIRT at each visit. There hasn't really been an efficient way for Tanya and Elaine to see whether a patient was already screened or not. So basically, they've continued to see patients and screen patients every time they come in. So obviously, some of them are going to be repeat visits. And basically, screening status over time talks about those patients who were screened more than one time. So 57% of those who were rescreened had no issues on the first screen or the second screen, and then 18% had showed improvement. So that means that basically they had screened positive for some issue, they were given referral or brief intervention, and then they actually improved and showed no at-risk problem on the subsequent screening. And then another 16% their symptoms persisted between tests or screens, and 8% had scored negative and then scored positive. So that's that. So between November and February, we also tracked whether patients followed up on referrals that were made at the previous visit, and only 21% of patients followed up on referrals, while 79% did not. Reasons for not following up with referrals are going to be tracked more carefully in the future. So this has been an evolving project for us in the sense that we've been gathering more and more different statistics as time goes on, just trying to tease out different aspects of the SBIRT experience. So with that, that's my part. I'm going to turn it over to Tani. Tani is a licensed marriage family therapist, and she has been our SBIRT screener from the beginning. And she's going to talk about some of the lessons that were learned in the practice with UCI. And but before I do that, are there any questions so far?
No, I think people are just waiting to get more information before they ask. Thanks.
Okay. So with that, I will turn it over to Tani. And welcome, Tani.
Good morning. So I'm one of the clinicians who's implementing the SBIRT at UCI, and I'm going to discuss a little bit of my experience with the SBIRT program and some of the lessons learned. Number one is having a particular personality. You have to be very flexible with the work duties, getting along with different personalities and positions to the registered nurses, medical assistants, medical students, ROP, management to maintenance, being patient and being genuine with personnel. In regards to flexibility, there would be times when I would be upstairs doing follow-ups, and I would get a page in the intercom to come down to the nurse station 3, and because the patient is crying inconsolably, and I would have to respond to that. Also, doing the dance. I call it the dance. Sometimes when we're seeing a patient, a doctor would come in, and we have to excuse ourselves, and there'd be times where I'll be coming in and out, and also being able to respond to crisis, knowing the agency's protocol, the 5150, and for example, also last month I had to do an adult protective service report.
Can I say something? Because those who are outside of California might not know what 5150 is, but 5150 is basically the involuntary status of a psychiatric patient here in California.
Thank you. And having good clinical support system. Although Elaine and I, we work for the county, we try to have contact with the county, even though it's like we're stationed at UCI, and so we attend supervision, peer consultation, even having the two clinicians, Elaine and I, on site. We consult with each other, and also the administration of tools. They conduct screening in a conversational manner. Elaine and I, we memorize our tool, and so when we walk in, we're not reading off the questions. We'll make it more of a conversational and
more of a personal experience.
More of a personal experience, and we try to, like what I call hook with the patient, try to connect with the patient, and so because we're a stranger coming into the exam room, they're actually wondering, who are you? And so I try to find some connection with that patient the first 5 seconds I come in. Use clinical skills to assess other health issues. And that's why I feel it's important that a clinician implements the SBIRT, because if those questions that are asked, it doesn't identify psychosis or mania. Also, so there are times a patient will say no, but if there will be a gut feeling, and I might ask the question, for example, question number 4, so feeling down, depressed, or hopeless. Sometimes a patient would immediately say no, but if I were to ask the question in a different, reword it in a different way, they would could respond yes. Or using psychoeducation, they might say, oh, I'm not depressed, but I have low energy. I just want to get out of my room, and and so they'll, when I do a further screening, I would educate the patient with the PHQ-9, and actually give them that piece of paper and have them see those symptoms that they said yes, they're displaying.
Which, if I could just add in here, that speaks to the advantage of having it administered by an individual. I know there's been there are lots where they actually hand the SBIRT tool to the patient and they fill it out themselves. Excuse me. But if the person who is, the clinician is asking the questions, they can ask it in a different way, or at least ask, if the person mentions the symptoms, then they can say, okay, that the answer would be yes rather than a no kind of thing.
Yeah, and let me just say too that when Tanya and Lane first started doing the screens, they had like their county ID, but yet they were working at UCI, and so when they would come in, people would go, well, who are you, and why are you asking these questions? And so they had a little bit of a legitimacy problem, so that's when they had to get the UCI badges. And actually, because in some of the SBIRT literature they talk about the white coat effect, we tried to get them white coats, but we couldn't find one small enough for Elaine. But the badges definitely helped lend some validity to their presence in the UCI.
Because when they had the county badges, some of them, weren't they concerned about maybe being from social services?
Social services, taking away the kids, or,
Yeah. Next slide.
Yeah. Getting known, being involved, attending to staff, management, and resident meetings, continuously introducing ourselves to people, because the UCI is a school of medicine, doctors come and go, and so apart from the meetings, when we see a new phase, we're constantly introducing ourselves and telling what we do. Becoming a member of the clinic team, integrate into clinic culture, becoming part of a regular clinical staff and clinical full. It's really important to have a good rapport with the UCI staff and make ourselves feel like we're part of their family, the family of UCI. And support tools. Develop tools for daily tasks. We developed a daily tracking sheet and also a referral half sheet. In regards to the referral half sheet, it's a half sheet of piece of paper where we have referrals that we're more likely to refer our patients, because even though we developed a resource directory, which is 25 pages, we have a little sheet of paper that we're able to easily give to the patients. One side is for mental health referrals, and the other side is the drug and alcohol. Resources, identifying resources to match patients' needs. Last month in April, the clinic was slow, and with the permission of our supervisor, we were able to visit a couple programs that we were already referring our patients, just to get an update on them, how's their wait list, and also we were able to see a new program that we heard about, and so it's something very important for the SBIRT is having a good set of resources for our patients. We don't want to give them something that we don't know about the program, or if the wait list is too long. We don't want to set them up for failure.
Bonnie and Lane have gone through quite a bit of work just working on the resources and making sure that when people call, there's somebody on the other side, that there's a viable program that can really provide some help for those patients.
Yeah, very true.
Next slide.
Yeah. Some of the barriers and issues with referrals to agencies, particularly in Santa Ana, we see more Spanish-speaking clients coming into the clinic, so there are some limited resources on that. Also, the lack of appropriate services, the one-size-fits-all group therapy. We had a program that we were referring our patients to, and we were getting feedback in that they were grouping everybody with any type of mental health issues into one group. And so the patients who were mild to moderate, such as for mild depression, they would be grouped with people with schizophrenia. And so kind of that would be kind of scaring them off and not coming to
making them feel uncomfortable and
yeah.
Yeah.
So barriers with referral agencies. Providers saying they don't provide those services. Sometimes, although we know of some programs, and we're referring our patients, and they exist, and we're referring our patients, they would be calling us back saying, hey, that place you sent us, they're saying that they can't give us services, or we don't qualify, or So what we're doing lately as a result of this is that we're doing three-way calls. The patient, myself, and the provider, and the conversation changes immediately, and they're more apt to giving them services.
Excellent.
Questions?
Oh, did you do it?
No, no questions yet. Thank you.
Oh, I didn't get that.
You didn't get that one? Oh.
Okay.
You want to say something about it? It was a bit...
The barriers for tracking client data, you know, the inability to write SBIRT notes in the patient computer file. That's something in the process that they were trying to be able to write in their system, the computer system, and the reasons of their being positive and where we're referring them to. At this time, we don't have.
Because initially, they would be doing the paper screens, and then they would be documenting in the electronic health record whether they were positive or negative for the screen for the doctors to see. And now they're trying, so they haven't been able to do that yet.
So everything's in paper and in file.
But so the UCI is trying to make it so that basically they can document more into the chart.
Right. This is Dr. Emily Dow. I'm the interim medical director at the FGH sites in Santa Ana and Anaheim. I'm based at Santa Ana, and we instituted EMR, the electronic medical record, last year, and it's still a work in progress, and we would like our SBIRT workers to be able to document in the EMR, but so far what we have been able to accomplish is there's a section where it says event, so event type, so we can see there where the SBIRT worker has had an encounter with the patient. That's the only place where we see that, but we're working toward Tanya and Elaine being able to document their encounters with our patients as well.
Okay, so with that, I'm going to turn it over to Dirk and Dr. Dow to talk about UCI's experience, maybe more from a direct practice and also from an administrative view.
Yeah, this is Dirk Zerbo. I was one of those people who said, what was SBIRT? I joined at the end of June of 2012, and it took us a full year from that point. And I'd heard about it when I first came on board, and we had some different transition of management and medical directors. So it took a while to get it going. And I think some of the logistical things were touched on, I mean, background checks, but part of it was also getting office space, phones, computers, badges. And then the other part was integrating Tani and Elaine into the culture of the center, bringing them to staff meetings, so they actually would be seen as part of the team. I think that was important for not only them, but for our staff, that they felt like, okay, they're working with us, they're not outsiders, and we had them actually come to staff meetings, introduce themselves.
And we also did a little bit of training, too, for the residents.
Mm-hmm.
We had some of the experts, the SBIRT experts coming from UCLA to do a little bit of training for the doctors, just so that it helped the staff to have more buy-in, because they didn't know who Tanya and Elaine were at that point. And I think now it's a different situation.
Yeah. I think the biggest thing was the bilingual piece, and that they really are seen as part of the team. I mean, that's been really critical, and that they are on the floor. When I walk downstairs, I'll see them in the hallway, and you just know they're there. They fit in. I think the staff's comfortable with them. The patients are comfortable with them. I think the challenge for us, and every system's different, is every year we have new residents. So it'll be a new experience starting in July again. We have a whole new batch of residents where they'll need to learn. So the education is going to be an ongoing process.
Well, and Tani was saying how she's so well known there that a patient was saying, "What? Hi."
Oh, yeah, the other day in the waiting room, a patient from the other side of the room
lobby.
waved to me, and I waved back, and three others were waved And I guess they thought I was leaving too long.
They didn't know which one.
And one of the other pieces of nice is we have authorization coordinators who refer specialist visits, but having Tani and Elaine actually be able to tell us who's really responsive. It's kind of like a double check. Who's out there that's able to get appointments. It's helped our patients as well, and I think our clinicians to know they have some comfort level where to send those patients. So that's from an operational standpoint. I know from a clinical standpoint, Dr. Dow is much closer to it than I am.
So I really second what everybody else was saying. Tanya and Elaine, our SBIRT workers, have been so well integrated into our clinics. We have 27 residents, family medicine residents, and about 6 faculty physicians and a nurse practitioner. And we're so used to seeing them every day on the floor, going into exam rooms and seeing the patients before they see us. And as you probably know, there's usually a delay in us getting to see the patients in the exam room. So I myself feel reassured when I know that they're already in there attending to them, so that the patients feel like they're not being neglected. So there's somebody in there, a warm body and warm personality, talking to them and really showing that they actually care about their mental health. And whether substance abuse issues arise, they're really a wonderful asset to our clinic. And they've just, we thought that this was a one-year grant that we were working on, but we really want to make sure that this continues, because I don't know, what we would do without them now, because they're such an integral part of the clinic.
Well, and not only that, but they're seeing patients on the first floor, which is their family health clinic, and then family medicine, and then the OBGYN department upstairs heard about them, and they were really envious and mad that they weren't getting some SBIRT workers too.
Yeah.
And then basically the UCI, I guess he's the medical director for integrated care, Dr. Kilgore, right?
Integrated medicine.
So he's been so impressed with the results that we're coming up with and the stats that we're working towards publishing some results and hopefully gaining some increased funding for expansion of the program. So
it's been a win-win for everybody, for us physicians, providers, and for the county, for UC Irvine, for our patients especially.
And from our perspective, when we, again, we started this because we felt like we wanted to integrate behavioral health and primary care, but we saw it as a way of being able to identify individuals that were going unidentified, and that because our purpose is to provide services to those who need it, and so it's turning out to be that way. Although, as Cary mentioned earlier, the surprise was that we're getting far fewer positives on the substance use and more on the depression and the anxiety. That was a bit of a surprise to us. We thought we would see more in the alcohol and drug, and perhaps if this were in an ER or trauma center setting, that might be different. But we do know that mental illness drives a lot of medical issues as well, and so it's actually been, I would say, not a disappointment, just a kind of a pleasant surprise that we're identifying individuals who are in need of mental health services. And so when Tani and Elaine are performing these screenings, they're a primary function of what they do is the motivational interviewing, and the motivational interviewing obviously is it is huge in this, because that's where you get the individuals to recognize that maybe they do have an issue, and in a very non-confrontive way that enables the patients to take a look at themselves and come to their own conclusions with regard to maybe they do need to get some help and or at least change some behaviors. And so for us, I can see how it's become a critical service for the healthcare clinic, the primary care clinic. but but it's also been a big benefit to us because we're fulfilling one of our purposes.
Yeah.
So it's been a good experience.
I absolutely agree. I actually wasn't surprised that it was heavily mental, mood disorders rather than substance abuse because I worked there for the past 10 years and I know what our patient population characteristics are like. We are serving patients who are low income, very low health literacy, with very little means to resources that are in the community. And so some of them, as Bart said, don't even recognize that they're depressed. And I would have to say a majority of our patients, I usually have a sense that they have mood disorders, but there were a few that Tanya and Elaine were able to discover that they do have issues, mood disorders, depression, anxiety, also domestic violence issues, and kind of family stressors. So it's again, it's a very helpful, useful to have SBIRT on site.
I know that there, from everything I've read, traditional resistance on the part of primary care is to doing SBIRT is that, if they do get a positive, what do they do with them? And that would require time because of the very limited time that the residents or doctors have in the exam room with the patients. And so, there is a real concern there. Having these SBIRT staff there on site takes that burden away because they have the resources and can provide those referrals or even just the brief, the motivational interviewing. One other thing that was interesting is what we have found with our short screen that about 90, so if someone tested positive on a PHQ-2 or screen positive, and then the follow-up PHQ-9 was given, we were finding probably 99% of them were screening positive on the second screen as well. Same thing for the GAD-2 to the GAD-7 and so forth. And so we did consider for a short period of time that, well, why don't we just do away with the second level screen? Because, of the high correlation between the two. But then Tawny and Elaine brought up that they found it very valuable to do the second screen because that's really where they were able to do the motivational interview. I don't know if you want to speak to that at all, Tawny.
And do some psychoeducation. Sometimes patients, when they see that the result in a piece of paper, it kind of opens their eyes and say, oh wow, then I do have depression.
It gave them talking points, ways to connect with the patient and help the patient to see that they needed some help.
Yeah, and in when they do score positive, we do follow-up the following week, and the next time they come into the clinic. And so just to see, hey, how you doing? Did the referral that I gave you, did it help you? And if they say no, well, there's something that could help you with. Was there any barriers to get into the resource? So being there for 10 months and the increase of seeing the patient the second time or the third time has increased, and so we kind of know the patients more and more.
Yeah, that continuity piece is very important. Several issues that were brought up that I want to talk about. Having the SBIRT workers really actually make the work of the physicians more efficient because I used to have to, as a family physician, as you know, we are the primary care physician, so that patients who are in fact depressed or anxious bring those issues to us. They don't go see psychiatrists. They don't go see psychologists or seek out counseling on their own. They come to us as their first stop. And so I used to do a lot of counseling, and but these are patients who also have diabetes out of control, blood pressure out of control, cholesterol, heart disease, kidney disease, and so to fit in the time to address their mental health issues, that was really difficult in a 20-minute visit. But when we got the SBIRT workers, we could say, let's talk about what concerns me today. We have to start you on insulin, for example, and I'm going to have our worker, Tanya and Elaine, come and talk to you. Is that okay? So they have been real team members, and they have really helped us address the issues that we needed to address as physicians. Of course, mental disorders, mood disorders are our territory as well, but it's sometimes overwhelming for our residents and my colleagues to try to address everything. But to have Tanya and Elaine on site are a great help for what we need to do. And there was something else that came up, but as I said, it's been a win-win. And the continuity among our patients with Tanya and Elaine going to see them and following up on what the recommendations, their recommendations, that's a very important piece as well.
And I just want to say this is our first time doing this presentation, so I didn't put our tool in the PowerPoint, but I mean, maybe while you guys are thinking, asking questions, I can put the tool up so that everybody can at least see the screening tool that we're using. So.
Yeah, this is Chris. I can always include the link to the tools in my follow-up email, too, if there's any reference or resource information that you'd like the attendees to have, I can do that.
Okay, I appreciate that. And so while you're looking at that screen, I guess if anybody has any questions, we'd be happy to entertain them.
Perfect. I do have a few here. When you were talking about the amount of people you find with mental health concerns, here's a question for that. Do you have a breakdown of the mental health concerns discovered at screening, maybe a top 5?
Because the stats we're collecting are basically, mental health positive. We don't have stats that really talk about that, but Tawny might be able to talk, like on an anecdotal level, about what she's found in terms of what the majority of the mental health conditions are that she sees.
The majority are screening positive in anxiety and depression. I do have some who are going through some form of trauma, but the majority is anxiety and depression.
Have you had any psychosis?
A few, and it would be that in the room they're hearing voices at that moment, or I could sense something different of the patient. But
we've also found too that not only have Tawny and Elaine been able to identify more mild and moderate mental health conditions, but also we've had a couple of, like we said, 5150, which is a danger to self or danger to others or gravely disabled patients, and also they've made child abuse reports and older adult abuse reports as a result of their screening.
Yeah. Last month I had to do an adult protective service report for a 71-year-old female. She had reported to her doctor that her 47-year-old son, who was diagnosed with severe mental retardation, was hitting her. And so I remember the doctor coming in and saying, "What do I do?" And so I helped the doctor and actually printing out the necessary paperwork. And actually, I did come in to see the patient and disclose to her that the report was going to be made, and talk to her in a way that was going to be something positive. 2 days later, I followed up with the patient, and she was actually grateful for the first time her son and herself was going to get some services. She said even just for the basic needs, a bed, some covers, and some food. And so, I saw that as a good.
Another question, Christine?
Yes, they are coming in. Do you think it's possible to train existing staff to conduct SBIRT screenings and integrate it into their existing SOPs instead of bringing in outside screeners to conduct them?
Yes, this is Dr. Dow. I think it's possible. I think it would take a long time. I think having the mental health background that Tanya and Elaine have, and the ability for them to tease out, this is not just a questionnaire, but to be able to sort of sense that, the questions may not be answered appropriately, that some of them may not recognize what it is that they're feeling. I tend to think that, it's definitely, it's doable, just, run through the list of questions, but having that mental health background, I think, is really helpful. And that's why they're so well received by our patients and our staff and physicians.
To the extent, I think, too, that those existing staff are trained in motivational interviewing and SBIRT, and to the extent that that is their focus, it's definitely possible. But it's sort of like to the extent that they're not trained, or that's not their focus, or this is just another job chore that they have, it would definitely have diminishing returns and viability.
And something else, I know that there are other SBIRT programs, others, like I know San Diego County had a long-running SBIRT program that they were doing, and actually theirs was in several of the ERs and trauma centers, and they didn't use licensed staff. What they used were paraprofessional staff, so individuals that had gone through like a special training. I think it was through UC San Diego. It might have been San Diego State. I'm not sure which one, but it was a kind of an intensive training on how to do SBIRT, and they were more like certified counselors rather than licensed clinicians. And it was very successful for them. I think the advantage, though, of having someone who actually has a background in behavioral health and has a license and such is what Tawny was talking about, where because of her experience, she was able to tease out some things. She was able to pick up on cues and such with regard to psychoses or depression that's just not in the question itself, but she just understands what it is. And so there's definite advantages to having people who have that background and training rather than just training someone paraprofessionally, although I know that there's a place for that, but rather than just training someone who's a paraprofessional or training current staff to do that as an extra thing.
Okay, thank you. Excuse me. In these screens, do you touch on tobacco use at all? Because somebody here is wondering if screening indicates that smokers have higher occurrence of anxiety and depression.
We would love to lie, but our screening tool is right here, and it doesn't. We didn't ask anything about tobacco use. It probably would be something.
We actually screen everybody at every visit at the clinic site because that's one of the things that one of the HEDIS measures. I don't know whether people know what that is. So that is something that we do anyway. I don't know whether there's data on smokers having higher rates of anxiety and depression, to be honest with you.
Okay. Do you supply the patients with a do you supply the patients with a visual, like the standard drink card or something, so that they know how many ounces or what's considered a drink and a large drink?
No, I don't have any of those cards or anything I have, but I would describe the amounts, because in one of the questions is like 2 to 3 to 4 drinks or 1 to 2 drinks, and I was kind of like, if it's a beer, if it's with a small can, if it's a 40-ouncer, and I kind of describe what the
equivalents are.
Yeah.
Okay, thanks. Now, I do have another full question here, but a couple people are asking for those tools So I'll get that information from you afterwards, and then I will definitely include it in an email that I'll be sending out to all attendees. So that takes care of those people. Now, here's the last question right now. What do your doctors typically say to patients to encourage them to interact with the clinicians beyond the pre-screens? Can you model what is said so that I might in turn model this for our doctors? We have quite a few positive pre-screens, but the patients aren't getting from the doctor to the clinician.
Since the SBIRT workers actually see our patients before we do, we haven't actually made a point of telling our patients about them, because they introduce themselves, in a very professional manner, and our patients assume that they are part of our clinic, which they are. Is the question more about what we say to our physician colleagues and residents, or to the patients?
I think it was the patients.
Oh, to the patients. So, as I mentioned, the patients take for granted that they are a part of the clinic and part of the medical assistants, that they see the front office staff, and this is a clinic staff person who's coming in to ask some questions. So we haven't really had the need to explain to patients.
Yeah, and they say that the less distance you have from the integrated service, like the less squares or the less different doors they have to go to, the better the contact will be with the patient. So in other words, if you're trying to get the patient to wait to see somebody, or maybe to come back at a different time or something, it probably wouldn't be as effective as, because our SBIRT workers are going in while the patient is waiting for the doctor. There really isn't any reason for them to not want to discuss the issues. And again, Tani and Elaine are good at.
Okay. Sometimes, there are times when I actually ask the SBIRT workers to get involved, in which case I would tell the patient there is a mental health professional who's going to address the issue with you today. Is that okay? So I sort of ask for permission, and then I get them involved.
Okay. Mm-hmm. Yeah. I guess that's our answer.
That's it for the questions so far. Thank you.
Okay, so I guess we're done with the presentation then.
So we hope that you have found this helpful. This is something a little bit different that we've tried here, and we feel very good about what we've been doing. Our results are just 10 months worth, but it's pretty robust data, and as was mentioned, we plan on doing a paper on it to demonstrate just how this has gone for us. But we have found that that this has been a valuable service to provide this. It's not what we started out to do. We started out wanting to do this in an emergency room setting, and that is something that we would like to still pursue at some point. But we're very pleased with how it turned out in the end, and working within the primary care setting.
Okay, thanks so much. I'm just waiting to see if any more people submit any questions. I think this is very informative, and I really appreciate all the time you spent putting this together. Okay, I don't see any more coming in, so I will we'll say this is the end for your presentations. I'm going to actually take the screen back so that I can show them our APTC website, because we have something brand new on there that I think they'll all want to see. So let me just get that here. A second. Okay. Thank you again.
Thank you.
Thanks. You're welcome.
And send me those links. or the documents that I can put in my email.
Okay.
Okay.
Thank you. Okay, so this is Chris again, and I just want to give you a brief overview of our the National SBIRT ATTC website.
Cary, this is something that you can
second.
later.
Let me unmute you. Okay. Okay, there we go. Okay, that way they can carry on their conversations. So this is our website. I'll send you the link when I send out the email. We are part of a national network of ATTC locations. That's Addiction Technology Transfer Center. In addition to the 10, I think, regional centers across the country, there are also 4 subject area national ATTCs, and we're the one for SBIRT. Now, this is our page, but if you want to find the ATTC in your area, you just go to this one, and you can click on whatever region you are, and this will bring up your regional ATTCs. They have their own special topics here on the side. They have their own trainings and webinars and a lot of good information. This is the California one. They are really heavily focused on SBIRT trainings too. So this is a great resource for you to find. Get in touch with them, find out what they have available, and I think that will be a great resource for you. These are the 4 regional focus, or the 4 national focus areas. One on frontier and rural. Another is on the national Hispanic and Latino populations. Then we have northern, or national American Indian and Alaska Native, and then this is us at the bottom here, SBIRT. Now, on our website, we have a lot of information, and this is just a quick overview of the Rethinking Drinking is one of our digital tools, and this is where you can actually link to the site to order them free. Here is our National SBIRT Strategic Plan, and this is brand new. I just put this on the website yesterday, but it's been in development for quite a few years. If you're interested in SBIRT and don't know what the requirements are or where you can find the information for your state, this is brand new. You would just click on this map, and it will take you to our IRETA site. IRETA is the Institute for Research, Education, and Training in Addictions, and IRETA holds the National SBIRT ATTC grant. So here is where you would just click on your state. Let's see, you will find Nebraska, and you will see the different codes here and updates terminology for, and this will be for any state. All this information has been entered for you, so I think that'll save you a lot of work looking for this information. Now, we also have a list of trainings and events, and you can click on any of these. There's quite a few coming up here, quite a few webinars. So you can click on those, and then that will link you to the registration. Our products, these are the products that we have, and this will take you to links for the webinars for this research snapshot. We also have a toolkit for practice in which you can find many of the screens, also brochures for patients as well as staff, and a lot of other information. We also have the webinar library, which is where this session will go later this afternoon. It has all our webinars on it, along with the slides that you can download. You can view these on demand whenever you want. Now, if you would like to have a trainer come to your facility, there are lots of trainers across the country who are qualified to do that. Just go to Special Topics, the trainer registry, and similar to that other regional map, you can just click on a region, and this gives you all the trainers who have been approved by the local ATTC. And then if you click on any one of these, it will give you all their background information and contact information. So that's a great way to link up with some trainers in your area. And we are always revising that. Now, we have items right now. We just have one, but we will be loading this up with SBIRT items from other agencies too, not just ATTC. Here are our partners. We work with NORC at the University of Chicago, and they also are providing quite a few webinars that you can get to by registering through our website as well. But they have theirs on a separate webinar library, so it's great to go there and see a bunch of great topics that you can view on demand. Now we have a few online courses here. This one is specifically for dentistry. This is a wonderful, I think it's a 4-hour course done by the Pacific Southwest ATTC, the Foundations of SBIRT. And then we have an Employee Assistance Professional Guide. These are all available for online. Now, we have an occasional newsletter called the SBIRT Alert. And this will give you information on upcoming conferences, upcoming webinars, interesting articles, research, other items of interest for SBIRT. And you can, to see the latest one, you would just click on this, and this is what the SBIRT Alert looks like. So you can register for this too and get it in your inbox. Again, it's not every month, it's just whenever topics come up. And this is just an overview of SBIRT. So it gives you just a real basic understanding of how SBIRT works. So I think that's it for our website. Again, there's a lot of information here and across the whole ATTC network. So we hope you take advantage of this. I will include these links along with the information from the webinar that we just had, and you will get an email from me tomorrow morning with the certificate of attendance, the link to a CEU order form, a link to this recorded webinar and the slides, and the resources that are included. So I think that's it for today's webinar. I appreciate you all joining us and hope to see you again soon. Thank you.